Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
Yeah, I know. So,
Brutal.
but it's fine. So, anyway,
All right. Well, let's do this.
Should we do this? I guess. Should I piss
Yeah.
off all of Medic and EM, Twitter, Instagram, and the world? Maybe it only makes
I'm here for it.
It only makes it better. I think, like, so not to sort of go too far down the rabbit hole, but I forget. Do we do like some intro? Like,
I already hit record.
Oh, so we're just going. Okay, shit. All right.
Yeah,
all right.
yeah. We're here with our resident in-house podcast pulmonologist Nick Ghionni. Pulm Toilet on the Instagram, which I still think is the greatest handle ever.
Dude. Hey man, you like my thing? I got it. You like it right there? Boom.
I love the neon sign.
Dude.
I was thinking of getting one.
Hell, you should get one. Totally.
It's baller.
Not, I know. My wife was when I put that up, she's like, this has gone too far. I'm like, I don't know if you know this, but I'm like a pretty big fucking deal. So
yeah, big deal. Rich mahogany.
Yeah.
So you I was working a night shift and you messaged me, and apparently you pissed a lot of people off.
I am so bored, right? I'm like, let me just start some shit. So this is the problem. I'm going to be honest with you. The problem is that with the amount of information that there is, like, to learn and like to be had and all that stuff, we've turned to different things, right? We've turned to like podcasts, we turn to like IG, we turn to Twitter, we turn to like websites like mcrit, and like, don't get me wrong, like I use them, I love them, like, I've talked to Farkas like back and forth a few times on Twitter about certain things, but when that supplants certain like core things, that becomes an issue. Number one. Number two is that one person's sort of cult of personality, like you really need to sort of vet like what that information is in some way. So I think like things like SCAPE, and I haven't even got to Brash syndrome. Like I think those things like need to be vetted more. So for example, like there's been a few times I picked up patients in the ICU in the morning, and we're going through the presentation like, oh, Mr. Jones is a 67-year-old man, he's from Upper Darby, he's fucking watching the Eagles, he ate a bunch of like hot dogs or whatever, and now he's blah 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 blah, he has SCAPE. And I'm like, okay, SCAPE isn't real. Like, this is not a real diagnosis. It's not in Harrison's. Like,
just real quick, hold on, pause. I think
most
people know, but sympathetic crashing pulmonary
edema. Sorry. Okay, yeah, sympathetic crashing acute pulmonary edema.
Remember, you're talking to cavemen and women paramedics and
big
EMTs
masturbation,
here.
Big circle jerk. So, like, SCAPE is this sort of like very nuanced topic that is born out of like really the MCRIT world. I mean, it was MCRIT's first podcast was on SCAPE like in 2009 or something. Essentially, and it's a little confusing in the literature because like some will lump it under acute heart failure and some won't. Like if you look at like the Internet Book of Critical Care, like Josh Farkas, who like writes that blog, again, who I respect, I think he's great, etc. But like he does a lot of mental gymnastics to like make it separate than acute systolic heart failure, right? With like hypertension. So by definition, it's hypertensive emergency. So when the residents tell me, oh, he has SCAPE, I'm like, no, he has hypertensive emergency, and its clinical manifestation is pulmonary edema. So like, and then the question becomes like, are they volume overloaded? Are they not volume overloaded? Is it like a HFpEF guy, and then they just got hypertensive all of a sudden for some reason? They do a lot of sort of like mental gymnastics for, like for some reason they have some sympathetic outsurge, like some sympathetic surge, right? There's like, I don't know. There's like some substrate, like something happens. They're emotionally stressed. They are exercising. They're doing a bunch of cocaine, and they have some sympathetic burst that then causes pulmonary edema, and then it's like very specific, like hypertension and like pulmonary edema and like they're going crazy. You put them on BiPAP, and you got to give them this like fuck ton of nitro, which we'll get into because it's like it's just out of control. But so my issue is that this is not a separate thing. Okay, it's not a separate thing. The ED, some ED docs, because like all this stuff is emergency medicine literature. Like they want it to be a separate thing, and it's not a separate thing. Okay.
The gist
Yeah.
from the reading I've done on SCAPE, and I'm an idiot. I'm just a paramedic here, but the stuff that I've read about SCAPE
Yeah.
is that it seems like a catch-all term. It almost seems like reading a death certificate and you read the cause of death is cardiac arrest.
Yeah.
It's like, okay,
Yeah.
that
No, I mean
tells you what happened, but it doesn't tell you
yeah.
why.
When you read like what it is, I mean, it just reads like acute hypertensive heart failure. Now, whether you're overloaded or not is like two separate issues. The thing is that like when you name this syndrome, it like comes along with these specific things. Or like and if I asked you, I think you would tell me it's like high dose nitro and BiPAP. And then you give them a ton of nitro like to the gills, and then like you stop the pulmonary edema and then you cure them or some bullshit, right? So so then getting back to my resident issue, they'll say to me they have SCAPE. I'm like, all right, well, that's not a diagnosis, but we'll come back to that. So like, what are they on? They're like, oh, they got nitro. I'm like, oh, because of the like the Internet Book Critical Care. Oh yeah. I'm like, okay, how much nitro did you give them? Oh, they're on a drip. I'm like, well, how much is the drip? It's at 50. I'm like, okay, so they're on like 10 times less than what they tell you. Not that I'm saying that you should do it, that you should be bolusing or like putting these drips at these crazy high rates. We'll get into that too. But like they're not even going all the way. So I'm like, what are you treating? Like not only that, but like we're in the hospital. So I think like it takes as long to get a bag of Cardine as it takes the same amount of time to get a bag of Cardine as it takes to get a bottle of nitro. So in the hospital, there's no, like in my opinion at least, like nitro is fine. I mean, it's more of like sort of a preload issue. And I know it's like, oh, that's why we got to give more because of the afterload, and we'll get into that as well. But like the when you have patients on it for a while, they do get a headache, right? Like you get this like rebound headache that is not comfortable for them. So like why? And everyone gets so up in arms, like the nursing staff and stuff, and like rightfully so, because there's only so high you can go on nitro. So when ask the nurse like, hey, make the nitro 500 an hour, they're like, are you insane? So what you'll see a lot in these threads is like, oh, the ED doc stands by the bedside and he makes the nitro drip like 500 and they don't leave. Like that's not like it's cool to break protocol sometimes, but like it's just unnecessary. Like it's unnecessary flexing that's based in just a bunch of like nonsensical stuff. Furthermore, not that like don't take this for what it's worth, but there's been at least probably like 10 docs that reached out to me directly and like they're like, dude, you got to stop this madness. Like they say SCAPE. I'm like, what are you treating? I'm like anesthesia crit, like 4 pulmonary critical care docs, a heart failure doctor, a cards crit doctor, the guy that you like my friend from fellowship who you mentioned that was on, right? Willard, he's
Yeah,
a dude.
I was reading your was reading your discussion with him, and
he's
I was like nerding out.
The dude is a genius, number one. Number two, he definitely knows the event better than I do. So he's ridiculously all well rounded. So like when you have people that are that are actually experts saying that this thing is like it's not a thing, then what does that mean? Like what is like does that mean that like
what caught your eye? What caught your eye that brought you to an EMS podcast?
What do you mean?
Because
Like,
you reached out to me. There was a post going around with an EMS protocol that had a milligram push of nitro.
Yeah. I mean, so like,
and I think that's what gets you started on this.
So, I really like I like everyone, right? Like I think you know that by now. But
yeah,
my issue is that it's not even my issue with like any person or anything like that, right? Like it's not like this is not that serious. My issue is that, and I think the real problem is whoever writes these protocols, presumably these EM docs, like on these, like whoever does your like you probably know better than I do. I guess it's like EM doc that writes the protocols that you guys have to follow. Like they're just running.
It's generally a committee, but
yeah,
there's always a dominant personality on the committee.
I'm sure there is. And so so I have an issue with that. Like that's my issue, right? Like my issue is that because of this sort of undertone that this thing is taken, that is based not anything that's like in reality that I can tell. It's based on dog shit data. It's based on a bunch of retrospective garbage for like some catch-all diagnosis that you're like, you really can hurt someone with that much nitro, right? Like that's a real, and like that's my issue. My issue is that you have people running around, I think, and you can tell me if I'm wrong, but you get to Mr. Jones's home in Upper Darby, he ate like 4 hot dogs and his blood pressure's 240 over 120. He's diaphoretic and going nuts. You're going to say, oh, this is SCAPE. We better give him 500 of nitro. That's fucking
100%.
That's fucking crazy. If he dies, like just imagine if he dies, right? And they get an actual cardiologist on the stand. Not that you should like practice medicine, like thinking about if you get sued, but like just think about the optics. Like what physician is like what? None that I can tell. Like what cardiologist is going to say, oh yeah, like we give a milligram of nitro all the time for like never, ever, never.
Let me run you through what we would do
Okay.
in that situation with Mr. Jones. We'd respond to his house. We'd see him with this
In Upper Darby.
eye-popping dyspnea.
In Upper Darby.
Yeah, in Upper Darby. Going old Crozier style here.
Yeah.
He's got this eye-popping dyspnea.
Yeah.
We would put him on CPAP
Right.
for his shortness of breath
Sure.
and for the preload reduction, they tell
Right.
us. And then new protocols where I am, we would push 200 mics of nitro and then start a drip.
Right.
Low dose around 10 and then titrating up as needed. Old protocol before this IV nitro would be a sublingual spray and an inch of paste.
Right. Okay.
And then you repeat that spray every
Yeah.
3 to 5 minutes as needed.
Right. And, you know, like in the hospital, if that was me, I'd probably be asking for nitro tabs because we don't really have the spray. The paste we have, but like has to come up from pharmacy and it's just like they're sweating and it's like on them. It's a disaster. So I throw a tab in their mouth and then I go get some Cardine and like it's done. Now, you know, if you don't have nicardipine pre-hospitally, like that's an issue, but that's not even my point. My point is like that protocol that was circulated, right, in someone that has this like massive platform. Like if you look at the study that it's based on, which I did look at, like it's a garbage study. Like this study is garbage. Like this thing right here, I'm putting it in the camera so you can see it.
That is for the listeners. For the people listening,
this is garbage.
It's 2023 safety of pre-hospital intravenous bolus dose nitroglycerin in patients with acute pulmonary edema, a 4-year review
absolute
from the JSEP Open.
This is absolute garbage. So let's think of, so first of all, okay, why, and I'm not putting you on the spot, like just as a generality, like why do you load medications? Like why do you give a loading dose of something? Do you know?
We were taught that you need to rapidly increase the plasma availability of the drug, and then you start an infusion to maintain it.
Okay, so what you're talking about is steady state, right? So the question becomes,
yes.
When does a drug become steady state? After how many half-lives?
I have no idea.
Okay, so it becomes steady state after 5 half-lives. Do you load norepinephrine?
No, we just start the Levophed infusion.
Right. Why don't you load norepinephrine?
Now we don't have a protocol to load epinephrine. Typically, what we'll do though, that is a cop-out answer, but that's the truth.
But the answer is because norepinephrine has a short half-life, so it has steady state almost immediately because its half-life is short.
Okay.
Same thing with nitroglycerin. Its half-life is short. It's steady state almost immediately. So the fact that you're loading nitro makes zero pharmacologic sense. So to say that we loaded we give them a loading dose. There is no loading dose of nitroglycerin. It's fast on, fast off. It's just like propofol. It's just like norepinephrine. Like once you start it, 2 minutes, it's steady state because its half-life is so short. The reason why this study that I point out is garbage is because depending on when they cycle
this is the study, just so people know, this
is
the study that showed the high dose EMS right out of the gate for hypertensive SCAPE patients, giving a 1 milligram bolus of nitroglycerin.
Remember, so there's 2 things. Depending on when you cycle the cuff, you could completely miss that what that 1 milligram bolus did to the patient. Because in this study, they cycle the cuff like every 5 minutes. Like you're cycling the cuff for a drug that works quick and is off quick. So you could completely miss its action. Do you know what I mean?
Okay.
Number one. Number two is if you look at one of these other studies that I sent you, I'm gonna show you. Okay. Use of nitroglycerin by bolus prevents intensive care unit admission in patients with acute hypertensive heart failure by Levy et al. This one gets cited so many times, and it's cited in the guidelines. So very specifically, Crunch, right? I circled it in purple. I'm going to read it to you really quickly. So it says, when administered in high doses by intermittent bolus, nitrates result in greater arterial dilation and more substantial reduction in cardiac afterload, leading to favorable changes in central pressure dynamics. Sounds pretty good, right? Gives two little citations too, 8 and 9. So Nick went to look at 8 and 9. And the one that is listed 8 is this study that I sent you, which is nitroglycerin has more favorable effects on left ventricular afterload than apparent from measurement of pressure in peripheral artery. This was by Avolio in like 2000 and something. It's out of the ESC. I couldn't get the original copy, but what it said was basically in the cath lab, they measured the pressures at the aorta and at the brachial artery. Okay. After 300 micrograms of nitro, which is less than a sublingual tablet, your central pressure, your central aortic systolic pressure fell by an average of 22 millimeters of mercury at the aortic level and fell an average of 12 millimeters of mercury at the brachial artery level.
So the NIBP is not giving you an accurate.
The NIBP isn't giving you.
representation.
It's giving you dick. It's giving you dick for donuts or donuts for dollars.
All right.
You know this. You know this saying, right? So the anesthesia
Yes.
critical care person who is one of, I don't like saying followers because it sounds like too Jim Jonesy, but follows me on IG, who's like anesthesia crit CV, like does mechanical circulatory support. The dude is smart. He's like, dude, we're in the cath lab. We push 50 mics of nitro. Like we see change. Like we see it, right? And he has like, they're doing like balloon pumps, right? So they have an aortic pressure like at the level of the root of the aorta. Like they see the change. So the fact that Levy uses this study to like cite in his study to say that like high dose nitro changes, it's clear they didn't read it, right? It's completely clear they didn't read it, because if you would read it, it doesn't support his claim. Because by his claim, all you need is 300 micrograms of nitroglycerin, which is a sublingual tablet. We're just back to giving a sublingual tablet. That's the thing that drives me nuts. Lastly, in his own study, the author says, and I quote, "Such findings warrant in a future prospective randomized multicenter trial." So he's saying, like, you need to study, like this, like what he did was a study. Don't get me wrong. Like, I think it was open label randomized, like 100, like, no, this was a 395 one. There's another one that was like open label randomized. It was small, maybe like 150 patients, and it showed difference. Like, that's fine. But to the way this has sort of like been extrapolated to giving these massive doses of nitro, and then every single goddamn medic is in my DMs like, "Oh my God, you got to be on the truck with us. They're short of breath. We got to do something. Blah, 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 blah." I'm like, bro, I'm a fucking ICU doctor. Like, you think I don't know? Like, I get it. But like, you just can't do wild cowboy shit because the patient's sick. Like, you have to do things in a measured manner. Now, I understand your hands are tied a bit because of these protocols. So getting back to the original point, like, I think these protocols are crazy personally when you're given these high dose nitro medications. I mean, I don't know what else to say besides like
The thing is though, with these medics that are in your DMs, do they realize that I would say pre-hospitally, almost all of these patients with the shortness of breath, the crackles, the super hypertension, they're going to be going on CPAP or BiPAP.
Right.
That's going to increase the intrathoracic pressure, which is going to decrease preload, and you're going to get a drop in blood pressure.
Right.
immediately without the
Yes.
nitro. That's why
Yes.
patients instantly get better when you put them on CPAP. It's not
Agree.
because you're forcing air into the lungs.
No, no, it's
I mean, that helps their hypoxia, I guess, but the real benefit is from the preload reduction that you get. Am I
yeah.
wrong?
No, no, you're so there's a nice
So
there's a nice article by Willard isn't on it, but like the group that from NIH that he was a part of. It's called positive PPV, so positive pressure ventilation in the CICU in the CICU. So the one of the and it's actually a Cardio Nerds podcast too, but they go over, you know, like how hemodynamics changed in, negative pressure breathing and positive pressure breathing. And positive pressure breathing, as you mentioned, your preload does decrease. Your afterload also decreases because of the delta gap that you set up with positive pressure ventilation, because the thorax is like an enclosed space, right? So if you increase the pressure in the thorax, you then make that sort of by Ohm's law, it's sort of annoying, but you make that pressure, that delta pressure higher in the thorax, so blood can flow more freely out of the thorax, right? So your afterload goes down, and then you help contractility in the same way that you would help contractility if you did CPR, right? By applying pressure to the heart sort of around it. So no, you get immediately better. I mean, I just it's
so to me,
yeah.
to me, the non ICU doctor, it just it would seem irresponsible to then start a shitload of medicine that's going to it's going to drop their preload
If
even more and
yeah,
drop their afterload even more. Because then
it's
you're fucked. If they went from 260 to 70 systolic, that's a whole other host of problems.
the other issue is, yeah, I mean, that's a lot of issues, right? The other thing I think is that you're using the worst number on a non-invasive cuff, right? We know the non-invasive cuff, like the systolic diastolic is just like an algorithmic guess. Like it's okay at the map, right? Like it sort of can plot the map, but the systolic and diastolic number just like is an algorithmic guess. Like so you're type like and in all these studies, like every single one, the systolic pressure where it's sort of like, it's hypotension, is 90 millimeters of mercury systolic. So what you're saying, so the way that I read that is you could be 190, get a milligram of nitro, and then if your systolic is 91, you're not hypotensive, which is insane, obviously, right? Because like these are just relative numbers. If you get into the studies that I won't get into because it's going to bore everyone, like forget, the confidence intervals are super wide, which means that like you can't be sure of the treatment effect. Like it's just, I mean, it's poorly done literature, and to think that protocols are
Well,
written
yeah, I
around
mean,
this
here you
stuff.
see 29 patients for
Oh yeah, right.
this
Yeah,
one.
yeah, it's big. I know. It's what she's. It's 20. It's unreal. So like, I don't know. So like to sort of recap, we have a diagnosis that, in my mind, isn't real. I think in a lot of inpatient physicians, whether like, so maybe we're snobby or whatever, because like we get the patients and they're already like buttoned up to some degree, but um, you know, like I would, if I was a resident, like when I was a resident, I hate saying that because like I'm old, but when I was a resident and I went on ICU rounds with like my attending, like with Dr. DJV, is one of my attendings from my residency who was like very good. And I told him, oh, yeah, the patient has SCAPE. He'd be like, what? Like, oh, SCAPE. He'd be like, what the fuck is that? And I would say, oh, it's a da da da. He's like, where did you learn that? And I would say, oh, MCrit. Like he'd make me run laps or something. Do you know what I mean? And so now they're telling me it's SCAPE, and I'm like, okay, this is a fake diagnosis. It's not real. What does the patient have? And so they describe to me their symptoms. I'm like, what does that sound like? They're like, it sounds like hypertensive emergency. I'm like, it's exactly hypertensive emergency, right? So we have this like fake diagnosis that we've built up, and we have some shit literature to then say, let's give this medication with actual real side effects in massive doses. Now, and by the way, just to like be incredibly clear, nitroglycerin is a fine med for hypertensive emergency, especially if there's an acute heart failure component of it. That's not what I'm arguing. What I'm arguing is that in the earlier study that we were talking about, like 10 people got 3 milligrams of nitroglycerin. 3 milligrams. So what I'm saying is if one of those people
Friggin'
die,
nitro.
yeah, if one of those people die and you're on the stand in 2 years and they're like, they have some cardiologist come up and they say, doctor, what is the normal dose of nitroglycerin? He might say, or she might say, oh, well, tabs are 0.4 milligrams. I was like, oh, okay, 0.4, 0.4. How much did that patient get? They got 7 milligrams. Okay, so they got 7.0. So they got 10 times the amount of a normal amount of nitroglycerin. And then he'll say, or she'll say, yeah, like, did that contribute to their cardiac arrest? I don't know. I mean, that's a ton of nitro. Not to mention, one of these patients is going to be dissecting or have acute aortic insufficiency or is going to have
Okay,
hokum.
pause right there.
You're going to fucking kill them. Yeah.
I was trying to keep up with your nerd discussion with your friend who's the cardiac genius.
Yeah.
And he threw out all those terms like aortic insufficiency, all that stuff. And can you explain how high dose nitro would kill somebody with one of those types of heart failure?
If you have
other than just like dropping the blood pressure.
Yeah.
Transiently.
That's the point, is that if you have no valve and you drop, like, you're looking to stay away from things that decrease systemic vascular resistance, like your SVR. So, we like teach that sort of like as a part of the protocol. Like if you have if you have like aortic, or not, sorry, I didn't mean, I meant aortic stenosis, not aortic insufficiency or like aortic regurg. What I meant was aortic stenosis, right? Because if you have aortic stenosis, so it's like aortic stenosis hokum, so hypertrophic obstructive cardiomyopathy, which by the way, we see a lot more frequently now that we do a lot more POCUS. Like we used to think that it was, if like hokum was sort of like relegated to, a young kid sort of dies in the middle of soccer practice or something. It's like, oh yeah, hokum. And it's like sort of that EKG pattern. But if you have aortic stenosis and you're dropping your preload like super duper aggressively, some of these patients are preload dependent to like have enough of an output to maintain their body. So if you're dropping their preload very aggressively, that's not going to help them maintain forward flow. So, aortic stenosis is one of these things where it's incredibly annoying because, and especially if you have heart failure, because you're stuck between, dropping their preload so they don't like get pulmonary edema, but not dropping it too much so they have enough preload for their cardiac output. So, one of these patients that, and like aortic stenosis is like ubiquitous, right? I mean, it's like all over. Like a lot of people have aortic stenosis. So, it's sort of mind-boggling that, like, because you're a hypertensive patient that you pick up, right? Hypertensive, tachycardic, tachypneic, diaphoretic, like sort of on the cusp. I mean, that could be a number of things, right? You could be dissecting, you can have an MI, you can have a PE, I guess. You could have like a lot of things. So to lump these all together and call it SCAPE and then give them a ton of nitroglycerin seems crazy. I don't know what else to say. I think the inpatient physicians think it's crazy. Like I said, anesthesia crit, cards crit, a couple of pulm crit people, even some EM docs reached out and were like, yeah, dude, we use a lot of nitro in residency, but I don't use that shit anymore. Like, it's too much. So to circulate this like as widely as it was, and like based on this study, like this is not evidence-based medicine. You know what I mean? Like evidence-based medicine, like you have to evaluate the evidence. And if the evidence is garbage, like you don't base your practice on it. You know what I mean? Now, don't get me wrong. If someone was like, we have this evidence, maybe there's a benefit, we're going to do a prospective trial, be my guest. Now, I'm not going to do that, obviously, because I'm not like a researcher, but I mean, this is something that happens enough where I feel like it would be good fodder for that. You know what I mean?
So if you were on an EMS protocol committee, what would your answer be?
What meds do you have?
Nitro, some programs have labetalol.
Okay.
I don't know of any pre-hospital 911 service that carries cardine, which I don't know why, because it's such an easy drug.
So easy. So I think
it's
Like I
You don't
think,
even need to do med math for it
Mhm.
because it's not weight based.
Yeah, you can use nitro. Like I don't, like you could use nitro. Just don't bolus a milligram. I mean, is that I don't think that's like a controversial take, right? Like
No, I
like don't
yeah,
bolus a
I had
milligram. I mean, I
found
think it's like I don't get it.
well there was another thing on here. I wish I'm not going to go digging right now while I'm recording, but I was looking at the numbers of patients and it was a low number study. And actually, I found it. It
Which one?
has here of uh it is the Casey Patrick article,
Okay.
the
Yeah, yeah.
safety of pre-hospital intravenous bolus dose. What
Yeah.
was it? It was 235 patients, and it was pre-hospital patients that were intubated was 8% of them, which seems like a lot. I can't tell you I can't tell you the last time I or a colleague intubated a patient with pulmonary edema
Yeah.
because the non-invasive and the blood pressure reduction works so well.
Yeah.
That also being said, I mean, I see this a lot. A lot of
Right.
this Mr. Jones eating hot dogs. I mean, it's a daily occurrence.
I know
I
it's a
don't
common thing.
because yeah, we don't, and we do nitroglycerin infusions. We do the bolus, we do a 200 bolus, and then we go up on the infusion. I think the last guy I had, I stopped at 40 mics,
For nitro?
and it was one of those, yeah,
Okay. Yeah. And
40
don't get
mic on the infusion, and
yeah.
he was doing great.
Yeah. No, I don't I mean, I got to be honest, all the nitro I've used, I don't think I've gone over 100. Um and and not that I'm like a cardiac critical care. I'm not like I cosplay one, but I'm really not one. But like I mean, like it works. I mean, it's not like it don't work. Like it fucking works, especially when you have like a balloon pump in and you're getting. So when you have a balloon pump in, now you could argue about the utility of balloon pumps, which is fine. But if you have a balloon pump in, you get a central like an aortic root pressure, right? Which is some number. And then then usually we have like an arterial line somewhere, either in the fem or the radial, and they can be off. Like their systolic diastolic can be way off. You could be, and you're supposed to be kind of like 10 millimeters of mercury in the map. Like that's sort of like what's correlating. But your systolic diastolic can be like way off. Your map is sort of similar. My point is that to bolus a milligram of nitro with a cuff, I think I've demonstrated that, and there's multiple studies actually. That was just the one that he cited. So I'm not, why am I going to go digging? Like that's the one that he cited in the article. Um, it's not like. So I guess what I'm trying to say is like, let's say you have like Mr. Jones from Upper Darby, like you're being pretty cavalier. Like let me. I saw this thing on Instagram. Let me give him a milligram bolus, and his pressure goes from 220 down to 160, and you're like, hell yeah, dude! Like that was exactly what should have happened because it's not under 90, remember? So it's not like hypotension or whatever that means. Um, but by our numbers that we have, that means that if he went down 60 systolic on his non-invasive cuff, like if you somehow could know his aortic root pressure, I mean, how much lower would that be? It'd be more than 60. Would it be like 120? Because in this small study with in the cath lab from that paper I talked about earlier, like it was about half. Like it was about 12 versus 22. So does that mean that his aortic root pressure is in fact um like another 60 lower? Like so does that mean it went from, 220, now it's like 100? You're sort of dangerously close to that 90? I I mean that's what would make me nervous. And then how many of these patients got a stroke after? I mean, I didn't like sort of, I don't know how far they followed them into their hospital course. A lot of this stuff is retrospective. The one prospective study, I'm not sure how far they followed them. So, I
Stroke
don't,
from what?
what's that?
A stroke from what?
I mean, if your blood pressure is 260 and you make it 100, that's going to be
Sure.
that's going to be a, like, so, eventually that's going to be a stroke. Like, that's a million
Yeah.
percent going to be a stroke, especially,
And the heart ends up working harder. The already taxed heart's going to end up working harder to compensate for that tremendous drop in pressure. Because I guarantee you, Mr. Jones isn't 120 over 80 on a daily basis.
I mean,
He's probably hovering at like 180
that,
over 120.
that's the issue. So is that you like it just seems this constellation of symptoms that's like very common and could be a lot of different things: heart failure, PE, aortic dissection, valvular issues, right? What if he blew a valve? What if he has aortic regurgitation now or something like that's so like these are all questions, or like mitral regurgitation or whatever. And we're giving like massive doses of medications, and all of the study, like a lot of the studies, at least 3 or 4 of them, all it is we took a retrospective look at our charts. We didn't kill anyone, therefore it must be safe, which is not.
Well,
Yeah,
another thing that I noticed was that they have on here, and this is still the safety of pre-hospital intravenous bolus dose nitro, where their
yeah,
protocol was 1 milligram and they repeat 1 milligram,
yeah. You love this one.
and then that's it. It
You love
was
this one.
it was I believe it was a 37-minute patient contact time for EMS.
Yes.
With the half-life of nitro,
What? Yeah.
that's
What are you doing?
I,
Not doing shit.
I
in
mean, it's
37
almost
minutes.
like you're just dropping their blood pressure twice, and then
And
it's
then
coming back. And
well, that was the other thing is that so even if this bolus dropped the pressure, um like you're just going to be back, as you mentioned, like you're just going to be back to where you started.
yeah,
Right?
I'm looking at the notes that you sent me, and you wrote nitro short half-life. So even if intermittent bolus gets your blood pressure lower, it's short-lived, which brings you right back to where you started with
So
whatever
what the so then
you were
what
at.
what the so then what did you do besides expose the patient to harm? You know? Like, and I don't know. I just maybe it's because I don't work in the emergency department or I'm not a medic or whatever. Like, not that I'm saying that I could do that, but I don't know, man. I've treated a lot of hypertensive crises, and I throw 2 nitro tabs in their mouth before I put the BiPAP on. I ask someone to get the Cardine. I start their Cardine at 5, and everything is good in 15 minutes. It's maybe like,
I did,
like I don't
I
know
did enjoy the comment from the
which
one
one.
physician who was like, "Oh, this coming from the guy who couldn't handle it in the trauma bay."
Oh yeah,
Yeah, like you're
no.
some
I
idiot.
think
You're a
no,
pulmonologist in an ICU.
no. I think I know that was. Oh my god, that was so funny. Like the problem was
Yeah,
like
you idiot, Nick.
I know
Parents must be so
I know. The
disappointed in you.
problem is that oh my god, that was so funny. The like so guy he was so turned on. So like I was again like I like just fucking around like on Canva making these reels. And so I had like I was watching ER, like I've watched ER over again, which is an amazing show by the way. So I like saw that seat. I'm like, oh my God, like this is when they call and they've given the patient all the like your normal sort of fucking medic shit, right? Like bicarb and Narcan and like whatever. So I like purposely made it like just overblown, but then he like took it the complete wrong way. And like I not, I didn't like mean it that way, but then like it just sort of took off. And I don't know, I felt like it was like, how does he know I couldn't make it in the ER? I mean, he's right, but that doesn't mean you got to like bring it up. You know what I mean? And technically, it's not the ER, motherfucker. It was ortho. Okay, I didn't match ortho, not ER. So just get your facts straight. So, but like it's just like I guess to be honest with you, the thing that annoys me somewhat, um, they like they hide behind like, oh, the patients are really sick. Like, what, we just got to do what we can do, blah, blah, blah. It's like, yeah, like they're really sick. They're dying. They might need to be intubated. That doesn't give you a free pass to just do wild stuff, right? Like there needs to be some graded proportional response. Like, so, and I don't know. I mean, maybe you got to tube Mr. Jones. I'm not like, I mean, should we give him 2 milligrams of nitro to make his blood pressure lower so we don't have to intubate him? I mean, what's the bigger risk here? Would be my question. Um, Not to mention that you're using medications like incorrectly, not by their pharmacologic advantage, and not only that, but like in doses that are like not studied. I don't know, like I'm not really sure what else to
Can
say
I also
about that.
bring up the bigger problem
Yeah.
that I attended a lecture by an ER doctor, and it was about differentiating the cause of shortness of breath.
Yeah.
And so what do we see a lot? We see a lot of congestive heart failure, SCAPE. We see
Like,
COPD,
how is
asthma,
it different?
pneumonia,
How is it different?
pneumonia. And the doctor said, he's like, it doesn't matter if you're a paramedic, whether you're internal medicine, critical care, emergency medicine.
Yeah.
He said, with the tools that you have as EMS providers at all levels, without the advanced imaging, without the labs, suck at differentiating the causes of shortness of breath.
100%.
So now you could be giving Mr. Jones 3 milligrams of nitro for a COPD
or
exacerbation.
100%, or a PE, or
Yeah.
or
Or
anything else,
pneumonia.
or pneumonia. No,
Yeah.
I know.
Yeah.
So, like, but this is what I don't understand is like, and I felt like, I'm like, oh man, like, I'm like, did I miss SCAPE? I'm like, this just looks like hypertensive emergency to me. I mean, I don't like, I'm not a genius, but like the blood pressure's high, he can't breathe, and he's got heart failure, and he's like he's got +9 pitting edema. Seems pretty simple. Get the blood pressure down, put the BiPAP on, diuresis the shit out of him. Like, why does it, like, what, like, where did this nitro, like, where did this subset, and what the bros will say is like, oh, it's a sympathetic outflow, it's hypersympathetic tone from something. I'm like, how do you know that they have some sympathetic outflow that then leads to SCAPE, right? If I put you underwater, you wouldn't be able to breathe either, and you'd be fucking like trying to fight everyone. So, like, it's impossible to differentiate. Is there this sympathetic surge before SCAPE, or did Mr. Jones from Upper Darby just not take his amlodipine that day? His blood pressure went to 240. He flashed, and now he's dying from being underwater. Like, how do you tell the
That's
difference?
why he's having this sympathetic surge. Yeah,
Yeah, because he's fucking dying. I'll tell you what, if I suffocate you, you're gonna have a sympathetic surge. Trust me. But the way that it's the way that it's usually parsed out is like there's some sympathetic, like hypersympathetic activity or something. I think if you just throw sympathetic surge emergency in some way, shape, or form into a syndrome, everyone's like, wow, that's pretty fucking bad. Like, yeah, dude, you should definitely give him a ton of nitro for that. And without like thinking like, what are we talking about here? So I, unfortunately, I don't have like some, like, I don't have an answer. Like, there's no answer that I can provide you with. What I would say is think twice before you hit someone with 1 or 2 milligrams of nitro bolus, because I'll tell you what, if you kill that patient and that patient sues your ass, you're not going to have a leg to stand on, because this evidence, this quote unquote evidence that you have, is all garbage. So but
you made a comment that you will.
I made a lot of comments.
You see this, and like, I'll have to clean this shit up in the ICU. What kind of cleaning up do you have? What kind of cleaning up do you have to do frequently?
I'll tell you what I have to do frequently. That doesn't have to do with SCAPE, although I'm sure SCAPE comes up a lot of times. Like, what is not infrequent is, again, Mr. Jones. It'll be the same. It'll be something similar. Maybe it won't be such high blood pressure, but the Mr. Jones can't breathe. He's dialysis patient. He's from Upper Darby. He misses dialysis on Saturday, getting ready for the Birds game. He'll call EMS. He'll be like diaphoretic, can't breathe. I can't breathe. I have a cough. Some bozo will be like, oh, I hear wheezing, and then you give him an epi, Decadron, and 17 Duonebs. Then it'll be on BiPAP, and they'll call me, and then the ED will just carry that forward because it's anchoring bias. Like, oh, like Crunch brought him in, it's COPD exas, like, yeah, whatever. They'll call me because he's on a ton of BiPAP, and I go down. I'm like, oh, Mr. Jones, you have COPD? He's like, no, not that I know of. I'm like, oh, you smoke? Yeah, I smoked like 40 years ago. I quit though. I'm like, oh, I'll look at his chest x-ray. He's like underwater. He has +7 edema. And I'm like, why do we think COPD? And someone will say he's wheezing. I'm like, all right, so that doesn't mean COPD. So then what I'll do is I'll get him dialyzed, or if he pees, I'll give him 120 milligrams of Lasix. He'll pee out 2 liters, and guess what? He's off BiPAP in 6 hours. Like, was it COPD? So is it impossible for you to know that? Back to what you said earlier, it's impossible for you to know that. Like, is it COPD? Is it heart failure? It's usually a mixture of both. But sometimes, like, we're so grounded in one diagnosis that we oh, he was wheezing, it's definitely COPD. I'm like, what makes you think like this guy? And it's a prototypical person, right? They're obese, they have HFpEF, they all have atrial fibrillation, they all have some like chronic kidney issue, and they've all smoked, so I'm sure they all have COPD in general. But the thing you have to remember is that COPD is like this sort of subacute onset, right? Like generally, it's generally a subacute thing. Like, oh, I've had a runny nose the past 3 or 4 days. I've been using my inhalers more. I used to not make sputum. Now I am making sputum. Like that kind of stuff. You know what I mean? It's usually not like, I mean, one patient I remember last year was it was like that same exact scenario. When I talked to her, I said, "What happened?" She said, "I woke up in the middle of the night and I couldn't breathe." And I'm like, "All of a sudden?" She's like, "Yeah, all of a sudden." I'm like, "Did you miss dialysis?" She said, "Yeah, I missed my last 3 sessions." I'm like, "Oh, so it doesn't sound like COPD. It sounds like you're underwater." She's like, "I don't know." She's on BiPAP. She can't breathe. So we dialyzed her 3 days straight. And guess what? She's like, much better. So, there is like this cardiac wheeze. And like, I don't know if we still teach that stuff, but like there is a cardiac wheeze, right? I mean, fluid does make you bronchospastic. Just the fact that the bronchioles get inflamed from fluid sort of narrows them. So it can give you like sort of this wheeze. So you need to be careful, especially in patients that are predisposed to like, overload, whether it's ESRD, if they have heart failure, and especially if you don't have a good story for COPD, which is like I've been sick the past week. My granddaughter's sick.
No history of COPD.
No history of COPD is like usually a big one. Like, have you ever smoked? No, I've never smoked.
That's an indicator.
I swear to God, dude. One time, I swear to God, I'm like, oh, I'm Dr. Ghionni. I'm a pulmonologist. She's crying. I'm like, why are you crying? She's like, they told me I have COPD. I'm like, who told you that? She's like, the ER. I'm like, why did they say you have COPD? She's like, I don't know. I'm like, why did you come to the hospital? She's like, I was short of breath. And I'm like, oh, have you smoked before? She's like, I never smoked a day in my life. How did I get COPD? I'm like, fuck if I know. I'm like, let's think about this for a second. So then after 2 more minutes of history, it's clear that she has asthma. She's waking up at night. She had a recent viral infection. Like a lot of times, especially with COVID, this has happened a lot recently, is that it sort of, brings on asthma. And like people, even older people, 70, 80 years old, they get COVID and all of a sudden they have like these sort of like asthmatic symptoms. But I think the big tipping point is that, have you smoked before? I've never smoked. I'm like, all right, well, I think we can sort of safely rule out. And she's like crying. I mean, she's upset because she's told that she has COPD. I'm like, listen, let's just like pump the brakes on this for a minute, because I'm not really sure if like you do. So
interesting. Wild world, man.
So the old,
this was good. You got anything else?
No, I don't. I think I've said enough.
I think you eloquently laid it out. I do think people are going to get butt hurt.
Yeah, that's fine. I think that, and that's, maybe you get butt hurt, like get mad, go look at the data. Convince me that it's number one, different than hypertensive emergency. Convince me that you have any data that supports high dose nitro. And I'm all ears, but what you have currently is a bunch of retrospective garbage and medications where you're using them incorrectly by their pharmacodynamics. And on top of everything else, like there is a real like safety issue. So like I'm good with whatever. If it just spurs conversation or people like doing more research or looking more, like that's also I think worthwhile. But to just sort of lump together this like constellation of symptoms that we already have a name for, call it something else, and then justify giving a medication incorrectly in a massive dose that is actually potentially harmful, I think is irresponsible. Just, I don't know what else to say. So
I agree with you.
I'm team Cardine is just fine, and I'm team nitro sublingual, and then pop them on a drip, but not go absolutely bananas is just fine.
Yeah. So. Well, cool. Well, thanks, man.
Appreciate it. Crunch.
Stop
always.
Recording.
Yeah. Hit that
always. And I'll see you in Philly next week.
Yeah, dude. Hell yeah. I'll be there. I don't know. When are you giving a talk? Like